Welcome to this first in a mini series of interviews where I'll be giving different perspectives on the use of clinical functional MRI. In this first interview, I speak to Dr. BradFolley. Dr. Folley is a clinical neuropsychologist from Norton Healthcare, which is in Louisville, Kentucky.
Dr. Folley, thank you so much for joining me.
Absolutely. It's good to work with you. Thanks for having me.
So maybe just tell us a bit about yourself, like what brought you to neuropsychology, and sort of how did pre-surgical mapping become such a big part of what you do?
Yeah, sure. I'll try to be brief. I'm a clinical psychologist by training, a neuropsychologist. So in the States, um, neuropsychology is one of the branches of clinical psychology. So we work clinically with populations. And my interest, I started out studying schizophrenia in graduate school because it was the most interesting thing. I thought that experience of an individual with schizophrenia both was fascinating and also deserved a lot of attention for research. And as I developed my clinical skills, I began seeing more epilepsy patients. And that got me interested in the surgical aspects of epilepsy and localization of function within the brain. And so I transferred from my research career in schizophrenia to a clinical career in epilepsy. And I was fortunate to have grown up at a time during my education where fMRI was becoming one of the leading techniques for looking at localization of function in the brain. It just worked out for me that I was able to learn those techniques and combine that with neuropsychology and with my clinical expertise, and work now with the Department of Neurosurgery, where we use fMRI and other techniques, awake surgical mapping, to give the best outcomes for patients who have brain tumors and epilepsy and movement disorders.
Okay. So what, in your current role then, so you're looking at brain tumor patients, epilepsy patients, and what kind of procedures and different technologies are you involved with?
Yeah, sure. So, we kind of separate them out. Our brain tumor patients are individuals who come in. Usually these are individuals who are caught off guard, who have their first symptom very acutely. They come in, they're living life, and the next day they find out they have a brain tumor. They might have a seizure, or they might fall, or something like that. And so they're caught in a whirlwind of new information, life-changing information. Their families are affected. It's a hard time for them. In the process of that, we also have to make sure that we're treating them in the best way that we can. And that typically includes, from a neurosurgery perspective, to make sure we're helping them the best we can and to make sure we're not hurting them. So if you think about in terms of tissue, making sure we get a tissue diagnosis and making sure we remove as much as we can, a gross total resection, if you will. And then to make sure that the neuro-oncology team and the neurosurgery team follows up with the treatment of that patient long term. But for me, what happens is we acutely plan surgery, and that's where we decide if we need fMRI at that point, or if we need other techniques that would help the patient, again, best go through that surgery, meaning that we take as much out without hurting them. Mm-hmm. And the other side is epilepsy. And that's different because typically our epilepsy team has moved to a lot of stereotactic EEG. So instead of surface EEG, EEG can now be applied on electrodes that transverse the brain so that we can look at electrographic signatures in deep structures of the brain rather than just on the surface. That helps us localize where the epileptic zone is, where the epileptogenic zone is. And then we can use fMRI to see what eloquent areas are around that zone. Because when we map a person, so typically what we do is we will use those electrodes to map the individual. And fMRI kind of gives us a really nice starting point for that, so that we don't have to tire the patient out with hours and hours of mapping. We can kind of tailor it to stick to exactly what the fMRI shows us and have a more precise and more reliable mapping.
Okay. So for the time that you have been there at Norton Healthcare, how would you say the fMRI that you're doing has developed over time in terms of how the technique's done, but also how many patients you're scanning?
Yeah, I just looked at these numbers for this interview because I kind of thought we'd want to see what the volume was. And I think we started using, we've always used the Nordic system, and we started using it around 2017, really in full-blown clinical, volumes. And we've seen about 250 patients. We've used it on 250 individual patients since then. And that includes about 1 to 2 per week. And that can include someone with a brain tumor. Those come up as needed, right? So when a brain tumor comes up, we just get together and do that. And we typically schedule epilepsy in patients who are going through invasive monitoring with SEEG. Before they come in, we also like to have an fMRI on them at some point before they get those implanted so that we can have those ahead of time. So we can kind of have more freedom to schedule those out. But in terms of our center, I think it's really important that everyone appreciates the data from fMRI. So once you start out with a few patients and you show people what it does and how it can help, then everyone wants to use it. And I'll tell you something, even though we're at a regional epilepsy center, we're in a mid-sized city in the middle of the country, we also get referrals from other people who have heard, hey, they do this fMRI stuff. So I've got referrals from individuals, from physicians at other cities who send their patient here for fMRI because they want those data, and it might be too cumbersome to collect them where they are, or they don't have availability for it. So it's grown inside and outside. And I honestly think once you find a good initial team of people who appreciates fMRI, and then you show the rest of the group what it's capable of doing and what it can do, I think people will appreciate it when seeing it from inside their own center. And I think that we have a lot of interest in it, and we have a lot of people who are using it, particularly in functional neurosurgery. Yeah.
Okay. So when you say a team, who's in your team? Like, what types of roles do you have involved in this kind of fMRI process?
Yeah. So typically this starts from patient need. So we have a patient who might come and see a neurologist or a neurosurgeon for an initial consultation, whether it's for epilepsy or brain tumor or something like that. And we have fairly informed clinicians who might look at that patient's scan and say, you know what, this tumor, let's say, for instance, looks like it may be really close to Broca's area or some area in the brain that we think is eloquent. And the surgeon is thinking, I'd really like to help this person, and I think I can take that out, but I don't know about that area down there. I'd really not want to hurt them. And I want to know what my margins are. I want to know that I can go in there safely without hurting the individual. And that's how it starts. So they'll consult me. I'll take a look at the scan, and I'll kind of put together a plan to say, you know what, this is where the localization of the tumor is. I'm worried about these areas. And then what I'll do is I'll plan function that will quote unquote activate those areas in the scanner, so that at the end, the map that we retrieve and that we analyze is particular and appropriate for that patient. It's specific for their localized anatomy. So I'll kind of put together tasks that I think will show the activation, the perilesional activation. And often what will happen is when there is significant perilesional disruption, we will actually see plasticity of function. So we'll see the VOI, the volume of interest on the fMRI bold maps somewhere else. And that's very important because we use those maps to decide if we're going to go ahead with awake surgery or not. So typically what I'll do is I'll meet with the neurosurgeon after I'd analyzed the data. We'll sit down together, and Nordic provides a really nice triplanar view, which is great because we can look with isovoxel. The brain is, you can look at it in the coronal, axial, and sagittal images all at once, which we can't necessarily do in our PAC system. And we will look down at it together, and the surgeon will decide if it looks like those margins are too close for comfort. If they think the fMRI shows a wide margin, we'll proceed with surgery without the patient being awake. But if it looks like we're encroaching on areas, or it's getting close, or we have to pass through areas of eloquence, then we'll use those fMRI data to make the decision that we may need to go on to an awake neurosurgical procedure, which is where we use a little probe with a small amount of, it's a bipolar probe, adjustable with a small amount of electricity that the surgeon can apply to the brain surface while I'm testing the patient behaviorally to see if there are disruptions in their behavior. And that allows us to define, even though fMRI has really good spatial resolution, it allows us to define those margins very precisely and allows the surgeon to get as close as possible without disrupting function so that they can get the largest resection that they can.
Okay, I was going to ask how sort of involved you are during the surgeries. How similar then are the type of tests you were doing during the surgery compared with the type of fMRI paradigms you choose? And also, is that important?
I think so. I think it's a great question because there are levels of complexity. So I remember when I was in graduate school and, we came out of this cognitive neuroscience. It was everyone was interested in cognitive neuroscience. So finding areas of the brain that are involved during a task that light up in the scanner. And that could get pretty complex, looking at facial recognition or the timing of memory. And for that, we went from block design paradigms to more refined event-related paradigms, looking at the timing of this stuff. And really, we can't do that for these neurosurgical individuals. We have to keep things pretty simple. So as complex as they are in the scanner, they get even more simple when we're in the operating room. So if you think about most of the things we do in fMRI, we have the patient do a task for 20 or 30 seconds, and we watch that hemodynamic response rise and fall, and then we compare that to some baseline task. In the operating room, the timing of things is very different. So typically patients are asleep while the surgeon does the initial craniectomy and removing the skull, and then we wake the patient up slowly, and no one wants to be there. I mean, the patient doesn't want to be doing this. No one wants to be doing this. So we try to get in and get out as quickly as possible, which means we need to have the task with the highest sensitivity and specificity to make sure we're going to see a deficit if we stimulate. We need to make sure that our electrical stimulation is at the right parameters and high enough to cause a deficit, but not enough to cause a seizure. And then to go through this as quickly as possible before the patient tires out or can't handle it anymore. A good example is for language. A lot of what we do is based on very simple tasks, just like confrontation naming. So we'll get a baseline of the patient on showing them pictures and asking them to name them, or describing something and asking them to name it from a description. And we'll get a baseline. We'll know what the patient can do and can't do. And in the operating room, we make decisions based on errors that they make from very reliable pre-baseline testing. And in the fMRI scanner, it's a little different because, as you know, we don't really know what people are doing in the head, right? And that's so it's really difficult. And in the operating room, we have to make sure that we know that the patient is doing the tasks that we've asked them to do, so that any disruptions are correlated with that, so that we can make a very fast clinical decision. And so that is a little bit different. And a lot of things that we do with fMRI are covert. We ask the patient to do it. We can use all these techniques afterwards to make sure they did it. What was the last word you remember saying? Or, we can watch them press buttons to make sure they're doing the task. But in the operating room, it's a little bit more direct and it's a little bit more black and white.
Okay. Yeah, there's different considerations, practically speaking. So we don't always see a sort of strong, or if any, neuropsychologist involvement in fMRI services that we might go and visit for training, for example. How, I probably know what you're going to say, but how important is that? And is there anything that you would say or any advice you might give to centers who are building an fMRI service and don't have that same kind of involvement with neuropsychologists?
It's a great question, and it's actually difficult for me to answer because I've been involved in this for a long time. So I started doing this in the mid-1990s, again, when fMRI was a novel technique. They were using it in research. And so along those lines, I've always done fMRI. So translating it from my research career into my clinical career was very easy. And I had the skills to come and use that clinically. A lot of people don't. It's a new thing to them. They haven't used it in their training or their early careers, and they have to learn it anew. And I think while there are guild issues, and certainly in the United States, a lot of that has to do with billing and who gets to bill for a certain code or something like that. And that can cause competition between services and things. And as a psychologist, we don't run hospitals. Hospitals are run by physicians. And so oftentimes it's more challenging or difficult for a psychologist to be heard within that system. And I think part of that is showing people what you can do and showing people what's available and showing where your expertise is. I'll tell you something that I tell people is that, nothing against radiologists who are doing this now, but I tend to think of fMRI. To me, it's not a radiology. It's not a radiologic study. It's a study of behavior. Our dependent variable is behavior. We are interested in the person's behavior, which is why I think it's so important that you have a behavioral specialist somewhere on the team. It's wonderful to have them directly involved in doing it, but you need to have somebody who is dedicated to studying and analyzing behavior, because that's really what we're studying with fMRI. And those paradigms as psychologists, and I'm including you here, with those paradigms are so important to understand how do we quantitatively study behavior. And I think that is a particular passion and an area of expertise for psychologists. So I think that's important. Unfortunately, a lot of psychologists come out not having the fMRI experience. And I was fortunate that was always just part of my education, always part of what I did. My dissertation used fMRI and DTI. So it was very easy for me to use that background to direct kind of my clinical career as well.
Yeah,
so,
okay.
And it made it easy for the hospital system because they had somebody here already who knew how to do that, had been familiar with it. So I think it really depends on the training of the people, what their areas of expertise are, and how they can contribute to that. So if you have a team of even a psychologist and a radiologist working on this together, that's really important. If both of them have different areas of contribution, I think one of the things that's really important, we tend to think of fMRI based on the pretty pictures and the blobs on the brain and the rainbow colors. But all of that really is based in the behavior of the patient and making sure that the paradigms that we use, that we know what we're talking about, that we know that those behaviors are really being elicited reliably by the paradigms. And I think that's where psychologists can make a great presence in doing this. Yeah.
Mm-hmm.
So people have different needs of how they divvy up the work and which professionals are involved in that. But at the end of the day, it's about the patient and making sure that whoever's expertise can be used for this in the service of the patient, that they really use that to the fullest extent. And I think we've done that here.
Okay.
Yeah.
Nice. So when it comes to, obviously you are studying behavior and you're doing many tests prior to them coming for their fMRI in the first place. Who prepares them for the actual tasks and who kind of runs the tasks? Because I know that can vary quite a lot between different centers.
Yeah, I'll tell you about our team. So typically, so we have me, and I work with a psychometrist, so somebody who's dedicated and trained to give psychometric tests. So as a neuropsychologist, when I want to understand someone's behavior, their memory, the attention and problem solving, I have very specific tests of function that I can give them outside of the scanner to understand how they're performing on those. We also have a technician separate from our MRI techs. So we have somebody who we've trained by going to a lot of conferences and a lot of fMRI training centers. And there are several, at least in the US, there are several kind of weekend, 2-day kind of courses that you take.
Yeah.
As well as, if you come before the ASFNR or whatever conference, they have a lot of these trainings. He's been to many of those. And I've worked directly with him so that he trains those patients so that the MRI techs can focus on making sure the MRI parameters are correct and they've got everything they need on the console and the scanner. He will meet with the patient, do some testing that I've asked him to do. We test for aphasia. We test for any difficulty with reading or, vision, all of these things. As an aside, it's really funny because we have patients, I think patients try to be nice. But we've had problems in the scanner. We've had things upside down. We've had headphones that we think were working, but weren't working. Mm-hmm. And patients are reticent to say, hey guys, I don't hear what you think.
Yes.
And so we have to work with them in a very dedicated fashion when they arrive to say, if something seems weird, let us know. If you don't understand, let us know. But he also makes sure that they're trained. I would call it training to asymptote. He makes sure that they're so well trained on this that when the task comes up in the scanner and we say, hey, remember that task where we asked you to think of as many words as possible without saying them? They know exactly what they're supposed to do because they trained it with him. And so what he'll do is show slides of exactly what they'll see in the scanner.
Okay.
We have it on a PowerPoint and show the slides without the actual, stimuli that are the different letters from what we use
Okay.
to make sure there isn't that contamination. And they go through it, not in the scanner, but they go through it with him to make sure they can understand. In addition, he gives them some screening measures for aphasia and dyslexia and things that I need to know about when I analyze the data to make sure I understand what I'm seeing. And then they go in the scanner. We usually do a scout, first of all. And then we get right into our MP Rage. So our, good gray white differentiation anatomic scan that we use simply for co-registration so that we can co-register the fMRI data onto it. We go into our DTI data. So everyone gets a DTI session as well. We do a 60 direction DTI. I've looked at different things, and it looks like that gives us the best bang for our buck. And that takes about 12 minutes or so. And then we get into the fMRI paradigms. So for the first few, the patients don't really have to interact with us. And then when we get into the fMRI, we usually do about 4 paradigms because that's what people can take. And that lasts about an hour for that whole session. And then we're interactive with them. We're speaking with them in there. How are you doing? Is there anything, we can do? The Nordic system is really good about making sure we test for the screen and the earphones and everything else. And so we make sure they can hear it. We also have lenses, diopters for people who wear glasses because they can't wear the glasses in the scanner with the head coil. And so we have diopters that fit into the goggles that aren't exactly their prescription, but we'll get them close enough to be able to see what's on the screen. So he takes care of all of that. And then when the patient leaves, we also have techs. Our MRI techs are dedicated to the fMRI. They understand the TRs and the timing and the things that we need to know from them as we set up from the activist system to tell them what we're doing. The patient leaves, the data are transferred by network over to my console, and I analyze the data using BrainX, write up a clinical report that goes into the medical record. And then I meet with the neurosurgeon who we actually sit down and use the Nordic system because I think that's the best way to visualize it and to look through it and so that they can click on the triplanar view to see all the things they need to see. And oftentimes there's some questions still. We co-register our data to a T1 MRI, the MP Rage, but sometimes the lesion is better seen on a T2 or something. So we often have to then transfer those data to the surgical planning system. Again, the Nordic system is great. It's seamless. We can transfer it there, and then we can open it up on the surgical navigation system and look at it there as well if we have to.
Okay.
So it really is a large team. Yeah.
Yes. And it sounds like you have quite a luxury in terms of having that one separate person that's really dedicated to making sure the patient understands exactly what they need to do and that they're going to manage through the scan, because it seems like, the successful failure is in a lot to do with the ability of the patient to understand what you're trying to make them do. So
training, I don't think it doesn't work to just briefly explain something to the patient and put them in the scanner and expect to get good data out of it. Taking 20 minutes, usually it's about 20 minutes beforehand to give a brief screening for cognition and then really explain to the patient what's going on and have them actually do it so that you can see what their overt behaviors are. Because in the scanner, they're covert. Can't move, they can't talk unless we're doing some kind of motor task. But to make sure that you can observe that they are doing the task the way you want to do it before you put them in the actual scanner with the head coil in the tube, then you can be pretty assured that they're going to do it correctly.
And what about if the patient is really, or you anticipate that they would really have some difficulties in completing even the kind of the simpler tasks? Have you used resting state clinically to look at any specific networks?
That's a great question. This has actually come up recently, particularly with our pediatric program. And I should say I'm an adult neuropsychologist. I have very little experience with pediatrics, but so here's my point of view. if I'm giving information to a neurosurgeon and I'm making recommendations based on a human being's brain and based on some kind of surgical recommendation, I want to know that my data are meaningful and reliable and valid.
Okay.
And that's why I like to see behavior, that I know exactly what the patient's doing, and I know that the data collected during that are representative of those behaviors, so that I can recommend to the surgeon what behaviors would be affected by the treatment. That's very important to me. Resting state is a little different because you're not seeing those overt behaviors. But in pediatric populations, it's very difficult sometimes to scan the children and get those data appropriately. So to get reliable language data and is more difficult. So a lot of times our pediatric team, which is a separate team, but they're using the same system here, are thinking about moving to resting state to see what they can do. In the adult population, I don't think I would use it as often based on our population, because our population of individuals have always been able to do the tasks. And I'll tell you, some people are limited and we have to switch to Nordic is really great. There's a whole section of pediatric tasks that are easier to do than the adult tasks, but they still provide the same behavior. And I've always had luck using either the full adult tasks or the pediatric easier tasks with an adult patient to elicit behaviors that I want to image using fMRI hemodynamic response. The pediatric team has more difficulty doing that.
Yeah.
And so they're considering resting state. For me, I prefer the elicit behavior. I prefer seeing fMRI data that's based on behavior that I know to make a surgical decision. And
that's the core of your expertise is about behavior. So that, completely makes sense.
But I also see why it would be helpful for those populations where it's not so kind of easy or automatic to do what I'm doing. So if the technique offers them something and we can show that it provides really good surgical outcomes, that it predicts what it needs to predict, then I don't see a problem with it. I just honestly don't have a lot of experience with it.
Yeah. That's fair. So, how do you think, in terms of kind of how fMRI is moving forward, will it replace the WADA test when it comes to lateralization? And maybe I'm also talking about not just language, but perhaps memory. What are your feelings?
I think we'd all like it to. So for somebody at our center, I'm the one who does all the WADA tests. So the test of cognitive testing under hemianesthesia. We introduce a catheter into one of the carotid arteries, and then introduce amytal or Brevitol into one of those that kind of inactivates that hemisphere for a few minutes, and then you can see what the other hemisphere can accomplish when that's taken out. It's kind of a reversible surgery, if you will.
Yeah.
But it's invasive. It's invasive, and it involves a groin stick, and it involves someone feeding a catheter up through the vasculature into the brain. And so it's very invasive, and it's not something you'd want to do on an average Tuesday if you were the patient. But for memory, it gives us what we want it to give us. It tells us that the patient won't be amnestic after surgery, or if they will, then we're not going to do that surgery. I think for language, we get wonderful results, and I think in the literature, I think the case is clear that we can use fMRI to replace WADA for language lateralization. I feel like it's very reliable. It's very robust. I have no problem using that for language lateralization. For memory, it's more difficult. And, I think about this a lot because we'd love to be able to not have people do the WADA procedure for memory. And that comes up when we're trying to remove the temporal lobe, or when we're trying to remove the hippocampus. For that surgery, we need to know that there are the hippocampus, the mesial temporal lobe on the other side can handle that, can form new memories. The problem is, I think, fMRI is based on timing, right? fMRI is based on, so we know when you're processing language, your brain is processing it at the time when you want to process it. So if you're speaking or thinking of words, your brain's doing that work right then. I don't think that's the case with memory. I think if you look at There's a long history on memory. The temporal process of encoding, consolidating, storing, retrieving is not all done right then. As a matter of fact, it's done at very odd times, and we've shown that it needs sometimes sleep and protein synthesis, and all of these things happen that I think are very hard to image based on a time course of hemodynamic response. I'm not saying it's impossible, and I think that there have been many groups who have shown group analyses where they've been able to look at activation of those regions. Again, we have to show that those activations are just as valid as in an individual patient and that they predict postoperative outcomes.
Yeah.
And I think we probably will be able to do that one day. We're actively working on it here. I know, speaking with you and Kathy at Nordic, I think it's a great interest of everybody. And I think that's what it's going to take, because we see the literature and we see people who are able to do this and who are able to image memory and to get an fMRI signature of that kind of personal episodic memory, which is the memory that we're really concerned about. I do think that we'll be able to do something that predicts that. I don't feel comfortable with what we have yet for memory for our patients when you're talking about making a clinical surgical decision to prevent someone from having a postoperative amnesia, because a lot of those surgeries are elective. These are epilepsy surgeries that are not being done to save the person's life necessarily. They're being done to improve the quality of life. So the last thing we'd like to do is improve their seizures, but leave them amnestic. So we have a neurosurgical team here that's very safe and I think minimizes some of the risk, but it does happen. But we still use both procedures. We still use the WADA if the patient looks like they're going to have a mesial temporal lobe resection. And then if not, we will use fMRI for all the other pre-surgical planning.
Okay. Well, there are so many things that I could ask you, and would love to ask you, but I am just going to take one last question in the interest of time. Just maybe sum up for us, if you can, how much of an impact, really, from the surgeon's point of view, you think the fMRI data are making?
I wish one of the surgeons I work with were here to answer that, because I think they get a big smile. They love the data. They love the data. So, and I try to put myself in, and not a neurosurgeon, I try to put myself in their shoes. You have this person's brain open and I don't want to say flying blind necessarily, but it's your responsibility to make sure you know where you are and to make sure you're navigating that appropriately. And fMRI gives them confidence and they really like to see it. And I'll tell you, now that we've worked together for so long, they trust me and they trust the system. So we've shown, and I'll tell you very honestly, the neurosurgeon, when we started doing this, one of the neurosurgeons I work with, liked to test me a little bit. So if I said, this area right here is Broca's area, or this area right here is Wernicke's area, when we were doing electrical stimulation mapping, he would make sure he tested that a little bit. Even if we didn't have to go to that area, he would test it to see. And every single time, we got a deficit when we hit the areas on fMRI that we noted a priori were those areas. And so that gave the surgeon an incredible amount of trust and reliability in the data. And I think seeing that, and then moving forward, they trust the data more and more. Obviously, you can't trust anything 100%. We always have to be careful with an individual patient. But again, it's starting out and building upon your team and building on trust and building on trust of your data. And I think once people have these systems in place for long enough with a team, they will trust each other and trust the data and see what it can do and see that it actually helps them, prevents deficits, and improves patient outcomes. It's certainly part of our center now, and it's not going to leave. We're all dedicated to it, so it's part of what we do. We do it like this now, and we always will.
Right.
Yeah.
Good. Glad to hear it. Well, thank you so much. It's been great chatting, and thanks everyone for joining us. And I'll catch you soon. Hope to.
Thank you very much.
Thank you.
Thanks, Vicky. Okay.
If you enjoyed listening to this interview, please do check out the other episodes in this series. Also, head over to our website or follow us on LinkedIn or Facebook. And feel free to sign up to the NNL User Forum for more information about future events.